Hi everyone, this is Jack here from Singapore, and welcome to the APSC JCS 2020 webinar. This webinar is in conjunction with the JCS week that started since the 27th of July, and we're ending this Saturday with our APSC Virtual Fellows Convocation on the 1st of August. Today, this session, our second session of the day is an APSC Consensus for the use of Ticagrelor in Asia, a rethink of our DAPT strategies, implementing the latest evidence in antiplatelet regimes to clinical practice. A date stamp, today is the 30th of July, 4 p.m. in Singapore. And this session is organized by APSC and JCS, endorsed by the Singapore Cardiac Society and ICP. This session is also sponsored by AstraZeneca. I'm the chair for this session, and my esteemed speakers are Professor Jules, Montalescot, Roxana Mehran, Sidney Lo. I'm going to introduce them separately. So my name is Jack. I'm the current president of the Asian Pacific Society of Cardiology, based out of Singapore. My first speaker is Prof. Gilles Montalescot. He's a professor of cardiology in France, but as we know him very well, he's very much involved in clinical trials and development of new drugs for the past 20 years, and of course, for many interventional strategies and technologies. Professor Roxana Mehran is going to also give a lecture. She's very much internationally recognized as a trialist, and she's really a very feisty lady who has worked very hard to deliver new trains of thoughts for DAPT strategies for the world. Dr. Sidney Lo is a good friend. He's the director of a cardiac cath lab in Liverpool, Australia hospital. And he's very much involved in a lot of multi-center trials. His interest is in chip intervention, heart failure, antiplatelet strategies, closure devices. And he's a great educator in his EPIC program in Australia. And we hope to hear him speak on the topic of chronic coronary syndrome. With me as my esteemed panel of panelists, we have Dr. Cynthia Papendick, emergency physician in Royal Adelaide Hospital, Australia, Professor Junia Eko from Japan, Professor Li Heng from Taiwan, Professor Ubendra Kaur from India, Professor Hai Chang Xie from Taiwan, and a good friend, last but not least, BK Kim from Korea. They are going to help me flesh out the issues and discuss around the topic of DAPT use. We will focus on Ticagrelor in Asia. A disclaimer, the content of this webinar is copyrighted by APSC and should not be distributed without the prior permission of APSC. The views and opinions expressed in this webinar are those of the faculty members and do not represent those officially of APSC. A bit of housekeeping, the content is currently live streamed through Rutherford Medicine and APSC Facebook and YouTube page. For the Singapore registered physicians, CME points will be awarded to attendees who are active for at least an hour. This session is pending approval and will be accredited by the EBAC for 1 CME point for attendees. You will receive your attendance certificate upon completing a survey sent to you by email after the webinar. Please feel free to click onto the Q&A questions, and we will answer all questions that are submitted one way or the other. The next session will happen tomorrow, and this is on biomarker on APSC consensus and future use case in diabetes, for troponin, for BMP, and of course serology for COVID-19 as well. This will be tomorrow at lunch hour. So with that, we're going to go straight up to the first lecture by Gilles, and we'll start with their lecture, followed by Roxanne's lecture, and then we'll go in the QA session straight away for a discussion. So let's start the first lecture. The lecture 1 will be done on the APSC consensus statement on Ticagrelor that Professor Jules has kindly helped out for us in Asia. So Sam, can we share the first lecture?
Hello, I'm Gilles Montalescot, and my talk for today is to discuss this consensus statement on Ticagrelor that was elaborated with many colleagues from the Asian Pacific region. So this is the first slide of this consensus. It's a treatment algorithm for patients with a STEMI, and on the left side here, you have STEMI patients eligible for reperfusion therapy, going to the cath lab for primary PCI, and being treated with DAPT. And of course, this DAPT should be Ticagrelor or Prasugrel plus aspirin. And this is very clear in all guidelines that we have internationally speaking, of course. For thrombolysis, we have new data, and this is the new data that we have from the TRIT study, looking at the combination of aspirin, Ticagrelor, and thrombolysis. I must say that in this study, the prescription of Ticagrelor was delayed, and we need to consider this because, of course, there is a risk of bleeding associated with aspirin, Ticagrelor, and thrombolysis. And in this study, most of the patients were treated initially with Clopidogrel and aspirin, and there was clearly a prescription of Ticagrelor that came afterwards. And that's why in these guidelines we have said that we need probably, let's say, 8 hours at least after thrombolysis and initial prescription of aspirin and Clopidogrel. We probably need 8 hours before switching to Ticagrelor. And the duration of DAPT is recommended here. It's for 12 months in these STEMI patients, nothing special here in comparison to the other guidelines. This is another algorithm now for patients with non-ST elevation MI, and we have two different strategies here. Let's say conservative strategy, where you can use Ticagrelor or Clopidogrel. Prasugrel is not recommended in this setting because we have no strong data to support the use of Prasugrel in this situation where you do not go to the cath lab with the patient. And here you have the other strategy, which is an early invasive strategy. And of course, all options are open here, Ticagrelor, Prasugrel, or Clopidogrel, according probably to the bleeding risk of the patients. And you continue, of course, with antiplatelet therapy, aspirin, probably indefinitely, and you may use P2Y12 inhibitors for 12 months in addition to aspirin. Again, you have on the right side all the studies that we have supporting these recommendations. An invasive strategy in ACS, you can use, of course, Prasugrel or Ticagrelor according to the Triton and Plato study. The early use of P2Y12 antagonist is not recommended according to the COAST study, and in some way according to the ISAR REACT-5 study. And as you may know, we will get very soon the results of the Dubious study, which looks at the same question with Ticagrelor. So clearly, the early use of this strong P2Y12 antagonist is probably not recommended in NSTEMI. This is a slide where you have the Plato data showing the benefit of Ticagrelor over Clopidogrel for the primary efficacy endpoint, including here for the non-ST elevation ACS subgroup, and clearly it is the basis for recommendation on the use of Ticagrelor in ACS in general and in non-ST elevation ACS in particular. So this recommendation says that we should have, as much as possible, a 12-month duration of therapy with Ticagrelor or Prasugrel in association with aspirin in STEMI patients, in non-ST elevation ACS patients, roughly same duration of treatment, but be careful, pretreatment may not be recommended here on the basis of the study I mentioned before. Of course, this duration of the APT of 12 months can be adapted, and the minimum of 6 months is recommended in high bleeding risk patients. So most of these patients could have 6 months of treatment. If they cannot, you may discuss a further reduction in terms of duration of the APT, but this is what we say here, 6 months rather than 12 of course, it could be different in the very high bleeding risk patients. How shall we evaluate this bleeding risk? And we have this ABO score here. It's not really a score, it's a kind of guide to the physician to evaluate the bleeding risk of patients. A for age, and of course you consider age, and 85 is at a higher risk, is a higher risk population than patients just above 75. We have seen that in the different type of studies, like the Antarctic study, and you may consider also frailty of these patients. B is for bleeding. Is your patient a bleeder with a prior history of bleeding, ICH, GI bleeding, or a low hemoglobin level, which is a prognostic factor for these patients? And O is for organ dysfunction, liver dysfunction, renal dysfunction, bone marrow dysfunction, or stroke in the last 6 months. All these situations are associated with a higher risk of bleeding and should be considered for the duration of the APT especially. This recommendation says that PPIs may be considered for use in patients with a high risk of bleeding. And I think many physicians use PPI on a systematic basis, especially at the time of hospitalization. And now if you have to schedule surgery, especially non-cardiac surgery in your patient, this is a difficult clinical situation, and you may consider the bleeding risk of the surgery and the bleeding risk of your patient, and the whole question is, when can we stop the APT in this patient? So I would like to remember everybody here what we have in the North American and European guidelines for this situation. In the North American guidelines, it's all driven by the type of stents, BMS or DES, and this is what you see here. When you have a BMS implanted, it's 1 month of treatment in stable patients, 6 months with a DES, and you can reduce this duration of treatment up to 1 month for BMS, 3 to 6 months for surgery. In ACS, it's 12 months of treatment, BMS or DES, and you can have a reduction to 6 months, as we said in this Asian guidelines. But the door is open for a 3 months duration of the APT in case of scheduled surgery, kind of urgent surgery, oncologic surgery, for example. ESC guidelines are probably simpler. They don't look at the type of stents. They consider the bleeding risk, high bleeding risk versus low bleeding risk. Stable patients, it's 1 month for high bleeding risk. Of course, the same for surgery scheduled in this patient. And this is 6 months here for stable patients. And you can reduce to 1 month if you need to go to surgery. And in ACS patients, as we said in the Asian guidelines, 6 months is probably the best option for the patient with a scheduled surgery. So this is what we have for this situation, this tricky situation of scheduled non-cardiac surgery in patients with a stent implanted on the APT according to the different situations, ACS, no ACS, stable versus more unstable patients, and BMS versus DERs. Now there is another question, which is de-escalation of antiplatelet therapy, which is a question which has been tested in several clinical trials now. And one point is that if you decide to de-escalate from Ticagrelor to Clopidogrel because you consider your patient at high bleeding risk, don't forget that you may have a gap in platelet inhibition by doing this. And this gap may, of course, lead to thrombotic events, stent thrombosis in particular. So you may want to reload the patient with Clopidogrel when you de-escalate from Ticagrelor or Prasugrel to Clopidogrel. Long-term versus short-term treatment, we have lots of studies now, and we may remember here that we have studies saying that not only we should not de-escalate when the patient is at high ischemic risk, but we may want to continue the treatment with dual antiplatelet therapy for a period which is longer than the current 1 year recommendation of the APT. No recommendation for genotyping, no recommendation for platelet function testing in these guidelines. Just a slide to show you that we have data out there where aspirin was stopped early. Just to say that if you have a good reason to de-escalate, so drugs that you can stop is possibly aspirin, and you may want to continue with Clopidogrel, just like it was done in Stop DAPT2 and Smart Choice, or you may want to continue with Ticagrelor, like it was done in Twilight and Global Leaders. And in Twilight, it was at 3 months after the start of treatment. In Global Leaders, it was more around 1 month. So this is what we have. For very long treatments in high ischemic risk patients, no high bleeding risk, you may consider prolongation from 1 to 3 years in general with dual antiplatelet therapy. We have lots of studies suggesting that you always see a benefit on the ischemic side. You have also a higher risk of bleeding, so you may want to balance the benefit versus the risk when you do that. You may have seen in diabetic patients recently the same question asked with the THEMIS study, again with some benefit with prolongation of Ticagrelor and aspirin in these diabetic patients. And there is also a different option, which is the COMPASS strategy, where DPI, dual pathway inhibition, was prolonged for 3 years. And this is the association of rivaroxaban and aspirin in patients with high ischemic risk globally. So when you want to do that, you may want to evaluate the ischemic risk of your patients, and this is what we propose, a CVD approach. C for coronary, what is a coronary risk of your patient. V for what is vascular risk of your patient. So this is not the coronary risk, this is a risk of in other territories, PAD, cerebrovascular disease. And D for disease, what about diabetes, renal dysfunction, microalbuminuria, heart failure. And when you have some of these features, you have a higher ischemic risk for your patient. So with this approach, again, which is a global evaluation of the ischemic risk of your chronic coronary syndrome, you may want to do a choice like it is suggested here. When you have a high-risk patient here, according to this CVD approach, you may consider the bleeding risk, no excess here, and prolongation of DAPT is a possibility which is very much acceptable for the prevention of ischemic events. You may want to consider DPI, which is association of rivaroxaban low dose with aspirin in these patients, especially when they have polyvascular disease, when they have a prior history of stroke. This is another possible strategy. If you have an excess of bleeding risk with the ABO evaluation, a single antiplatelet therapy is to be recommended. And we have this pathway here, where you have a low-risk patient according to your CVD evaluation. And again, this is a good situation for single antiplatelet therapy, which does not mean aspirin. It could be Clopidogrel or Ticagrelor, for example, as a single agent in these patients. So a few lines of conclusions. In STEMI patients, treat early, treat strong. This is very important. You need dual antiplatelet therapy with the best agents, Ticagrelor or Prasugrel in combination with aspirin. In NSTEMI, start with single antiplatelet therapy. If you are going to have an early invasive strategy, and wait to see the coronaries in the cath lab before deciding for the use of Ticagrelor or Prasugrel. And if you have a PCI indication, of course, if you have confirmation of coronary disease, you will prescribe the second agent at the time of the coronary angiogram. The duration of the APT is 1 year after ACS, but evaluation of the risk-benefit is necessary to shorten the duration of the APT or to prolong it. If you have a high ischemic risk and a low bleeding risk in your patient. And we need to say that we, of course, need to re-evaluate regularly the risk-benefit of DAPT according to disease evolution and patient preference. So every time we see the patient in the consultation, we need to wonder whether this is the right antiplatelet therapy that the patient has at this moment, sometimes a few months after PCI, sometimes a few years after PCI. So these re-evaluation are necessary according to the evolution of the patient. Thank you very much for your attention.
Thanks again, Jules. Jules actually promised to call in,
Hello,
but I'd just like to tell you he's on vacation. Oh, are you online, Jules? I don't see you on the call. Okay. So anyway, that was, again, a great lecture. I picked up on a few points that I would like the panel to quickly discuss before we go on to the other tricky topic of where to go on Twilight data delivered by Roxanne later. So a few points I picked up. One is on the treat data on thrombolysis, because I think in a lot of countries in Asia Pacific is very relevant because there's still a lot of thrombolysis going on. I'm not too sure whether it's going on in a massive way in Australia as well, but that's something that we want to address. Secondly, we want to talk about the binary approach. Model after ESC are talking about high versus low bleeding risk rather than stand type, whether you agree or disagree. The third point that Jules mentioned was pre-treatment. And this is something I want to discuss with you guys about whether in the NSTEMI going to the cath lab, I know Japan goes to the cath lab very early. Do you still preload with your DAPT before bringing to the cath lab? Of course, then maybe I think Jules summarized a little bit about Sidney's lecture on when this translate from ACS to a CCS, but we'll discuss that a little bit further later. Can I start with Upendra's comments on treat and thrombolysis in Asia? Is this quite common that we go on Plavix, get thrombolyzed, and switch to Ticagrelor as a practice? You think that's a valid practice, Upendra?
Yes. Typically what happens that, as you very rightly said, am I audible?
Yeah, you're clear.
Hello?
Yeah, you're clear. Go ahead.
Okay, good. So typically what happens in our part of the world is that used method, and it's possible in the major hospitals, in district hospitals, we're trying to promote it, that the ECG should be done so that it is an ST elevation MI. And aspirin and streptokinase still is being used in, I would say, more than 50% of people, although tenecteplase has come in because they have reduced the price to some extent, and some governments are subsidizing it, some health insurance companies are promoting it. So they do get thrombolysis following, immediately when the patient comes, aspirin and clopidogrel is the usual way. By the time they reach the place where thrombolysis is done, and if it is streptokinase or if it is tenecteplase, then following the thrombolysis, that is continued. And some of the institutions, some of the places, they switch over to ticagrelor. Prasugrel, which was used a lot in the past, is not being used after the results that it has more bleeding, and ticagrelor is quite effective, although the comparison between ticagrelor and prasugrel is started coming in, especially with the ESR trials and all that. So then it is continued, and sometimes after 4 weeks of the treatment, some people, because of still the cost issue, although ticagrelor has also become generic in our country, but still clopidogrel is much cheaper. Some of them go back to clopidogrel and continue aspirin and clopidogrel for years for 1 year at least. And then there are combination tablets available. Aspirin and clopidogrel as a single tablet is available, and sometimes with a statin also. Aspirin 75, clopidogrel 75, and 40 milligrams of atorvastatin also. That makes some sense because compliance becomes easier, and cost becomes less. So that is the way we treat it. If the patient goes for pharmacoinvasive therapy, which again is being done in more and more centers in the metropolitan cities, that the patient goes for a angiography after 24 hours or sometimes 2 days, 3 days, depending on the clinical condition of the patient. Then angiogram is done, and following that, most of the situations, I think most of the cardiologists change over to ticagrelor, aspirin and ticagrelor, and continue it. There again, some of them after 4 weeks, because there is a trial, as you know, a small trial in which replacement of ticagrelor is done by Clopidogrel, and they found that the efficacy was not affected, numbers were small, but bleeding was substantially reduced. So that is the way, I would say, to sum up what is being done in our country. And primary PCI is being done. There, obviously, the patient is usually preloaded with aspirin and Clopidogrel, goes to the cath lab, does an angioplasty, and we don't use bivalirudin now. We go ahead with this. Thrombosuction is occasionally done with a big thrombus burden. And following that, what we continue is again, usually aspirin and ticagrelor for variable periods of time. But DAPT is given. They may switch over to Clopidogrel, but DAPT is given. And high dose of statins is given, and other things depending upon the LV function and other things. Thank you.
Thanks, Upendra. Can I just check, among those countries that does give ticagrelor upfront, how upstream do you think it needs to be given? If you're going to bring them to the cath lab anyway, should it be given all the way at the ambulance? Is it the practice in Japan, Taiwan, or Korea? How upstream is the DAPT loading given for STEMI cases? Probably, and then Dr. Eiko for Japan?
Yes, in Japan, ticagrelor is actually not used very often. So, we usually use prasugrel for ACS cases, and for STEMI patients, prasugrel is usually given at the in the ER. So in the ER for the STEMI patients, prasugrel is given, and for non-STEMI patients, we usually use prasugrel. But for those cases with non-STEMI patients, many institutions use after they see the results of the cath. And adding to that, in Japan, many patients treated with early invasive manner. So many physicians really, treat ACS patients aggressively. So that's a practice that we are doing, and in many institutions, we adopt early invasive treatment measure for those patients.
Thanks, Eiko. I know in Japan and Korea and Taiwan is very early. I know Gilles like to say, if it's very early, please don't preload. Load after you do the angiogram. But I think I'm not too sure. Maybe Professor Lee or Professor Shea and BK, what's the practice in Taiwan, followed by Korea?
In Taiwan, can you hear me?
Yes, go ahead.
Yes, in Taiwan right now, most of the ambulances now has the ECG. So right now we perform the pre-hospital ECG in the ambulance. So the ECG can be transferred to the hospitals if they see there's a very clear cut the ST elevation. So right now around maybe 1/3 of the counties or cities in Taiwan right now also under the instruction from the emergency physician, the EMT can load the patient with the dual antiplatelet therapy. So that's the condition we had right now in Taiwan. So right now we have pre-hospital ECG, and now we are trying to do the pre-hospital DAPT therapy for STEMI.
Okay. Dr. Jack, can you hear me?
Yeah, go ahead, please.
Yes, it's nice to meet you on the air. This is Dr. Xie Zhang speaking from Taiwan. So regarding the first question, you mentioned that thrombolytic therapy for the STEMI patient. Actually, in Taiwan, we did use the thrombolytic therapy for STEMI patient for many years already, because Taiwan is a small island and we have a lot of the classroom and the traffic also is very convenient. So we almost usually use the perform the PCI, primary PCI for the STEMI patient. So I think the thrombolytic therapy is not an issue for us to consider the DAPT treatment for the STEMI patient. The first question. And the second question, as Dr. Lee say, just like in our hospital, we prescribe the DAPT at the ER. So very immediately and very faster to prescribe this DAPT treatment for the ACS patient. And according to the guideline of the Taiwan Society of Cardiology, as we know, Professor Lee is the first author for the guideline recommendation. And in this Taiwan's guideline, we prefer to use Ticagrelor to the Clopidogrel to use it in the ACS patients. So I think more than 50% of the patient in Taiwan, the ACS patient in Taiwan will receive a Ticagrelor plus aspirin as the first choice of the DAPT treatment. That's my
Thanks,
comment.
Dr. That's a very good feedback. BK, is the practice in Korea also preloading with Prasugrel?
Yeah, so actually as for the upstreaming use of the antiplatelet, actually in Korea the ambulance use is not so common. So sometimes it's difficult because of some many different situations. So usually the emergency room or the cath room is studied first. Ticagrelor loading is started. So and also as for the thrombolysis is very similar situation with Taiwan. Is in Korea, even with some COVID-19 era, some centers recommended thrombolysis because of the combined situation. For example, is a high fever, some suspected of the MI patient. But anyways, so many cath labs already exist. And also is all system is equipped with for the primary PCI. So thrombolysis is very, very few, very, very few.
So for a large country like Australia, I just want to sum up this piece here. I think, what do you guys think of the upfront treatment for Ticagrelor? Because all the way down to the paramedics in the ambulance, because the evidence seems to suggest quite minimum benefit. So I wonder whether it's an established practice, Cynthia, in Australia in the ED. Does the ambulance give Ticagrelor? So you're muted, Cynthia, sorry. Oh, okay. So there
we go. Can you hear me?
Yeah, please go ahead.
Yes. So in Australia, the ambulance as routine will give even patients with just suspected cardiac chest pain, will give them aspirin as a matter of course and GTN. However, they do not carry Ticagrelor on the pre-hospital. In the emergency department, we would wait until we either have a very obviously ischemic ECG or a STEMI or results of biomarkers before we would give the Ticagrelor, but we definitely would load it as soon as we have that information.
Sidney, can I trouble you to sum up this quick topic first before we move on preloading as well as STEMI care?
So I think that Gilles gives a very good talk about these things, and I think the preloading story is a little bit weak in the evidence. So the preloading for Ticagrelor and Prasugrel, particularly for Prasugrel, largely results in increased bleeding. And in Australia, we tend, and most countries, don't give Ticagrelor in the ambulance. And of course, the combination of a pharmacoinvasive approach, there's a small risk. There's not a lot of data to support giving Ticagrelor at the time of thrombolysis. And even if you're practicing a stream kind of management plan, you're giving loading doses of 300 milligrams of clopidogrel, and in elderly people over age 75, perhaps half dose TNK and even low doses of clopidogrel. And of course, there's some confusion. I think that people probably will forget about the half dose TNK, about which one they're using, 600 versus 300 of clopidogrel loading. And of course, the confusion is then loading with ticagrelor as well. Ticagrelor in clinical practice in Australia is largely given 8 to 12 or the next day after whatever treatment has been done for the acute STEMI procedure. And I think there's a trend in older patients being treated with clopidogrel, even though there's set benefit with ticagrelor. And I think that's changed a lot with pathways in hospitals. And I think that's good. And prasugrel, of course, is going to be non-licensed anymore. It will actually be withdrawn from the Australian market. So we'll lose the ability to use prasugrel anyway in Australia. So it'll be ticagrelor versus that. I think that in TREAT trial, the median time to delivery of ticagrelor is around 11 hours. It's 10 to 11 hours. And I think that people were still worried about giving ticagrelor loading during thrombolytic therapy. I think that's a contraindication in the Plato Trial. And I think that we're still concerned about that because I think we saw some bleeding in Clarity in other trials with acute thrombolysis. That's why 600 milligrams of clopidogrel is not usually given with thrombolysis in usual care. So does that answer your question? So preloading is pretty out.
That's a fantastic summary, I thought. We haven't really quite covered the high and low bleeding risk, but I think I defer that. Maybe it's linked into what Roxana is going to talk about on the platelet monotherapy piece. So we will defer that. I just want to, because Jules is not here to speak for himself, but he's a strong advocate that if you are going to the cath lab early, the evidence seems to suggest that a preloading strategy may not derive that much more benefit. In fact, more than half the cases may defer for bypass strategy. So you're loading them, increase the bleeding risk without the ischemic benefit. So he favors loading post early invasive strategy if that's you have facilities for that. Upfront strategy upstream. How upstream? At home, in the ambulance. I think so far the evidence suggests as long as you give it an ED, going for a STEMI approach is probably fast enough. Whether it's faster than that, not sure. I think we have some caution if you are using a thrombolysis approach. The consensus in APSC suggests either next day or at least 8 hours before you switch from clopidogrel to ticagrelor if you are using full dose thrombolysis. So I think we'll go on to the second lecture by Roxanne, and the lecture will be on newer oral anticoagulation strategy. We'll focus on ticagrelor monotherapy. And of course, Roxana is going to talk a little bit about Twilight. So let's start.
Hello, it's truly an honor to be here with you today and to deliver the newer oral antiplatelet strategies with focus on ticagrelor monotherapy talk on this prestigious webinar of APSC JCS. Thank you for having me. It's important for you to note my disclosures specifically to the Twilight study, which was sponsored by Icahn School of Medicine and through a grant from AstraZeneca. The target of antiplatelet therapies has been well documented on the platelet receptors, and it's the P2Y12 receptor, the thrombin receptor, and the GP2B3A receptor. And of course, there's a lot about thromboxane and other factors like fibrinogen, von Willebrand factor, and of course collagen. But the cornerstone of treatment continues to be dual antiplatelet therapies with a target of the P2Y12 receptor inhibitor. This includes aspirin and the P2Y12 inhibitor, and the current standard of care to diminish the risk of stent-related and non-stent-related ischemic events. But prolonging dual antiplatelet therapies absolutely carries this higher risk of major bleeding, which has in turn been shown to affect mortality, morbidity, and costs. In fact, if you think about which one of these endpoints are important between myocardial infarction, spontaneous myocardial infarction, and MI, you can see that they're pretty much equally important. BARC3 bleeds are similarly important to MI. But it really is mostly driven by this BARC3C, where it becomes even more important than spontaneous myocardial infarction. So it's really, really important to make sure that we understand this in several of our evaluation when we're balancing protecting patients against ischemic risk, but also not exposing the duration of dual antiplatelet therapies. And instead of dropping the P2Y12 inhibitor, let's drop the aspirin and stick with the more potent P2Y12 monotherapy. Why does that make sense? Well, if you look at some of the early studies, and this one is with Prasugrel, showing that in presence of a strong P2Y12 inhibitor or blockade, aspirin really adds very little to inhibiting platelet aggregation. And this work by Paul Armstrong really does show a very, very important non-added effect with addition of aspirin Prasugrel. The same has been seen with Clopidogrel and Ticagrelor with a comparable inhibition of hemostatic system activation between P2Y12 monotherapy and dual antiplatelet therapies. Over a decade ago now, the Plato Trial set forth the use of Ticagrelor as the superior therapy to Clopidogrel in patients with an acute coronary syndrome treated either medically or invasively. The study with over 18,000 patients showed a reduction in the primary efficacy endpoint of cardiovascular death, MI, and stroke over the 1-year period in favor of Ticagrelor with a 16% relative risk reduction compared to Clopidogrel, with no difference in the overall safety endpoint of all major bleeding. However, CABG-related bleeds were increased with the use of Ticagrelor. This study impacted our practice tremendously. The guidelines were changed, and Ticagrelor became the preferred treatment choice for all ACS patients. The registry data also shows that the use of Ticagrelor has been increased drastically, but we have still some lingering questions. We had a low proportion of US enrollment, and there was this interaction with aspirin dosing in the Plato trial, specifically in those patients who received it in the United States with high-dose aspirin, and then that lack of benefit in the US for the drug because, most likely, because it was with a high-dose aspirin. This publication by Professor Stefan James does show a very important efficacy of Ticagrelor being accentuated with a low-dose aspirin as opposed to high-dose aspirin. And for this reason, we do have a black box warning for high-dose aspirin with Ticagrelor. So if less is more, can none be even better? And in fact, our colleagues, Professor Pocock and Professor Gersh, both wrote this very important telling editorial in JACC saying that we need clinical trials that can investigate the withdrawal of certain established medications to see whether this withdrawal causes or induces benefit, harm, or no difference at all. And it's really important to kind of have that because at the moment, we keep stacking new therapies instead of withdrawing the old ones. So this really led to an understanding that for the first time, we did see the withdrawal of aspirin in a small 600-patient study in the Netherlands by brave investigators who took patients with AF, atrial fibrillation, undergoing PCI, and randomized them to a triple therapy of warfarin, aspirin, and clopidogrel versus a double therapy of warfarin and clopidogrel by dropping aspirin. And by just doing that, they reduced bleeding by 64%. And furthermore, not only was there no harm in stopping the aspirin, in fact, the data was really, really protective of ischemic events, which actually doesn't make that much of a sense, and it could be that this is underpowered, but still there was no signal of harm. So the big question then came after that small study is that, can we safely withdraw aspirin when a novel, more potent P2Y12 inhibitors are being used? What's the role of aspirin? Well, there has been definitely no question that 2 studies have looked at Clopidogrel as the monotherapy. This is 1 month of DAPT followed by Clopidogrel monotherapy compared to 12 months of DAPT with aspirin and Clopidogrel. In the Stop DAPT 2 trial with the Zion stent, they showed a reduction in the net adverse clinical events. They were extremely low, but they did meet statistical significance. Most of this was driven by reducing bleeding. And similarly, the Smart Choice investigators showed the 3 months versus 12 months of DAPT with aspirin Clopidogrel, or 3 months of DAPT followed by Clopidogrel monotherapy to be non-inferior in ischemic events and a reduction in bleeding events, as you would expect. The Global Leaders investigators also performed the largest, close to 16,000 patients, where they the experimental strategy was all comers PCI receiving aspirin and ticagrelor for only 1 month, and then ticagrelor for the next 23 months, versus a reference strategy, which was the standard of care of what we're doing at that time for ACS patients, with 1 year of aspirin ticagrelor and then going to aspirin monotherapy. And for stable patients, 1 year of aspirin Clopidogrel and going to aspirin monotherapy, with a composite of death and Q-wave MI looking for superiority for this experimental strategy. Well, they just missed their p-value. The events were lower in the experimental group, but they didn't meet the primary endpoint. But to me, they were a winner because they showed no harm in the 2 very important endpoints of Q-wave MI and mortality. In fact, all of this was lower in the experimental arm compared to the reference strategy. But this really led for us to kind of say, we really do need to understand this better. And so therefore we designed, at around the same time, the Twilight Trial. This was a study of ticagrelor with or without aspirin in high-risk patients after PCI, in those patients in whom the investigator was placing on aspirin and ticagrelor, with an additional high-risk feature, with a primary objective to see if the 3 months of DAPT followed by ticagrelor monotherapy compared to 12 months of aspirin and ticagrelor can actually show a reduction in bleeding and no ischemic harm. We included patients that not only the clinician felt to go home on aspirin and ticagrelor, but also they needed to have a clinical criteria and an anatomic angiographic criteria to have them be at a higher risk for these events. We excluded STEMI patients and prior stroke patients, so it's important to note what we excluded. During an open enrollment period, patients received aspirin and ticagrelor throughout the first 3 months after PCI. At the 3 months follow-up visit in person, compliant and event-free patients were okay to be randomized, were legitimate to be randomized to aspirin plus versus a matching placebo with ticagrelor as a background therapy. And then they were followed in person and by phone calls for adherence to their meds by pill counts, as well as ascertainment of their clinical events. We had full follow-up of almost 99.7% of these patients. Well, ticagrelor monotherapy met 2 of the primary endpoints of the primary endpoint of bleeding was met, and the key secondary endpoint of non-inferiority for death, MI, and stroke was also met. Ticagrelor monotherapy was associated with a 44% reduction in BARC 2, 3, and 5 bleeding, with the numbers needed to treat of only 33. And ticagrelor monotherapy was non-inferior, met the non-inferiority margin for death, MI, and stroke. So we concluded that in high-risk patients who underwent PCI, who were treated with ticagrelor and aspirin for 3 months without any major adverse events, and antiplatelet strategy of continuing ticagrelor monotherapy resulted in significantly less bleeding, but no ischemic harm compared to ticagrelor plus aspirin. It's important to note that most recently in ACC 2020 and followed by a fantastic publication in JAMA just a couple of months ago, our investigators from Korea performed the TICO randomized trial. These were patients who presented with an acute coronary syndrome. And it was the evaluation of ticagrelor monotherapy versus DAPT in these patients, with a primary endpoint of net adverse clinical events, which included TIMI major and minor bleeding, and major adverse cardiovascular and cerebrovascular events that included death, MI, stroke, stent thrombosis, and target revascularization. 3,000 patients were included, and you can see here that 3 months of DAPT versus 12 months of DAPT, but the 3 months of DAPT followed by ticagrelor monotherapy after 3 months of DAPT was associated with a significant reduction in net adverse clinical events, with an absolute difference of 2% in this population. So, ladies and gentlemen, the take-home messages of this talk, and with this new evaluation on ticagrelor monotherapy, is that we really should be considering these new antiplatelet strategies by shortening the duration of DAPT and allowing for P2Y12 inhibitor monotherapy. We have shown unequivocally that dropping aspirin in a double-blind placebo-controlled fashion and continuing with ticagrelor monotherapy after a short course of DAPT decreases the bleeding risk without compromising ischemic protection. And we saw that even in ACS patients, that exact same message was carried through with the TICO study. So thank you so much for your attention. Please feel free to contact me through Twitter or my email listed here. Thank you again for having me.
Again, I'd like to thank Professor Mehran for the fantastic lecture. And so this is a great segue to move into this tricky topic of extended monotherapy. And I think she raised tons of observations. I'd like to start off by Dr. Upendra Kaur, who is also a co-I for the Twilight study there. And where has this changed the practice in India, since India was a large study group in this Twilight study? Upendra, please.
Yes, Jack, I was a participant, and I was in fact the kind of leading the Indian part of the investigation, which was quite substantial, although we reduced the numbers as the trial went on, but it was still quite a big number. And at least all the investigators, or plenty of them, have come to this field, and especially those patients where we think that bleeding risk is on the higher side, most of us switch over to pure ticagrelor and stop aspirin after 3 months. And some of us also, have gone through the global leaders trial, in which ticagrelor alone was also good, which the sum up information may not be, as lucid as our trial, the Twilight, has given. And Roxana has done such a fantastic job in, collecting the data, pushing all of us, and finally got the data. And I think it's a very useful trial, and many of us do this. But as I told you, still many of the people are going with aspirin and Clopidogrel for 24 hours, for 1 year. So that is there. But many of us have known this trial, practicing this one. At least I do it, and all my followers do it. And I have plenty of followers. Thank you.
So although there's a trial from India for Twilight, the current practice still stands at aspirin, Clopidogrel. Can I ask about the rest of the East Asian countries, starting from Taiwan? Because I think there was also a cohort coming from China led by Professor Han Yaling. This trial also covered Taiwan, Professor Lee and Professor Shea. Would you consider Ticagrelor extended or single monotherapy for this group of ACS patients then? Because it's rare to get any trials that shorten or withdraw therapy. So I think it's a great effort that the team led by Roxana came out with a trial that took off medicine rather than add on, which is rare. So is this a good strategy, you think, for Taiwan?
We don't have data about the only P2Y12 inhibitor monotherapy right now in Taiwan. So our guidelines still emphasize the importance of the dual antiplatelet therapy for 12 months for ACS patient. However, we are collecting the data right now in Taiwan because, in our clinical experience, some of our patients cannot tolerate aspirin due to the GI upset or mild GI bleeding. So right now we publish a very short paper about those patients about in recent 3 to 4 years in whole Taiwan, we have about 600 such kind of patient. They just stop aspirin very early after PCI and they receive only P2Y12 inhibitor therapy, including the Clopidogrel or Ticagrelor. Recently, we published a paper and they demonstrate that it's very safe for those patients to use the P2Y12 inhibitors therapy, a monotherapy only. However, it's a retrospective study, but we have very detailed data about coronary lesion and the PCI strategy for all those patients. So the paper was just published. And we also compare the efficacy and the side effect of the monotherapy with Clopidogrel versus the Ticagrelor. And we found that the Ticagrelor carry a better efficacy than the Clopidogrel. And the bleeding risk, the major bleeding risk actually is similar between the Ticagrelor and the Clopidogrel. However, I have to say that it's only a retrospective and a very scale clinical observation. So personally, right now in Taiwan, we prefer that if a patient do develop any event that cannot use the DAPT, we encourage the doctor to use the P2Y12 inhibitor monotherapy with either Clopidogrel or Ticagrelor.
Dr. Xie, is any other observation coming from Taiwan? So you're muted, sorry.
So personally, for me, I think I will adopt this strategy of the short duration of a DAPT treatment for ACS patient, just only for the high bleeding risk patients. So if the patients, if they don't have any high bleeding risk, I will give the patient as a guideline recommendation, especially for the ACS patient. I will give a patient for the DAPT for 1 year, at least 12 months. So this is my opinion.
No, I think your opinion is very sound and it's still very much in line with a lot of international guidelines, especially ESC.
Yes.
And maybe I'd like to hear from BK then, because in Korea, there's tons of studies, registry comparing bleeding, just bleeding alone and efficacy for Ticagrelor, Prasugrel. And you saw Roxana quote a TICO study for monotherapy at Ticagrelor. Coming from Korea, when I read the papers coming out of Korea, I get mixed messages about whether Ticagrelor does cause more or less bleeding compared to Clopidogrel or Prasugrel. Well, what is your take, BK?
Okay, so the first of all, our center, and including me, has conducted the TICO study mainly. And so actually, we definitely confirm the role of the monotherapy inhibitors, especially the high ischemic risk, for example, ACS, including STEMI and non-STEMI. So in this patient is Ticagrelor monotherapy is just balancing, optimizing the ischemic and bleeding risk. So actually, in the future, maybe this kind of P2Y12 mono inhibitor monotherapy would be the main therapy for the high ischemic risk. Sometimes, as everybody knows, some disease status has both ischemia and bleeding risk. For example, CKD or some older age. In this group, ischemic risk is high and bleeding risk is also high. So for this kind of population, it's not easy to choose the depth duration or the type of antiplatelet. So in this patient is very good target for the mono antiplatelet therapy group.
Thanks, BK. Junior, would this Twilight data persuade Japan to do a monotherapy study, you think?
Yeah, in fact, we don't use Ticagrelor very often. So this particular study doesn't apply to most Japanese physicians, but we are doing a lot of very short depth studies, including stop depth 2 studies, which many of the Japanese physicians were involved. And we have shown that 1 month depth following Clopidogrel alone was enough for not compromising ischemic risk, but reducing the bleeding risk. So many physicians are very much accustomed to using P2Y12 inhibitor alone without aspirin. And we are actually doing stop depth 2 ACS trial, which is to see if 1 month depth is enough in ACS patients. That's a current ongoing trial. And so it's, and actually the guidelines were changed this year. So this year they published the guidelines showing for the HBR patients, high bleeding risk patients, 1 month to 3 month depth is enough. For, for stable patients as well as ACS patients. So Japanese guidelines shifted toward very short depth with the continued use of P2Y12 this year.
It's always impressive to see these trials coming out of Japan. But again, because this webinar is for Asia Pacific, I like to caution that not everything done in Japan may be applicable for rest of Asia. I think the imaging guided PCI optimization rate in Japan is different. They have a very early pharmacoinvasive.
Yeah, more than 80% were done with IVAS guided PCI.
So I think the PCI practice, the not even pharmacoinvasive, is straight PCI in early. And the population is more elderly, the bleeding risk may be higher, the residual ischemic risk may be lower. So I think Japan is quite well, but may not be totally applicable to the rest of Asia. I think Dr. Pierre's point about maybe a shortened depth rather than removing for all is a good idea.
Yeah, but we are the shape of what's coming to you.
So we hope so. But maybe I just want to shift into the bleeding risk part, because I think in a lot of conversation is always coming to the assessment of bleeding risk, and there's always a sense of both sides. You know, there's always a sense that there's really very high bleeding risk in Asian. There's always a sense that there's overestimation of bleeding risk and undertreating the ischemic risk in patients. So I don't know where is it in North versus South Asia. Maybe we can hear from the ED perspective, Dr. Cynthia. I mean, you are an emergency physician. When the patient come in for a bleeding event, are cardiologists the culprit? What are you seeing in the ED?
We try not to blame you. We try not to blame you directly. But yeah, I think that the main thing is that often patients don't have a plan. There's no risk strategy to say whether someone's going to get in a car accident, unfortunately, although you could probably make one. Or, you know, I guess you could look at falls risks and other things, but unexpected bleeding is often more problematic than, yes, the GI bleed or those things, the spontaneous intracranial bleed. That's obviously a catastrophe, but it's also very, very difficult when you get a trauma patient, an elderly trauma patient who's already challenged. Having something where you had shorter amounts of time where patients were on these therapies would, clearly be ideal in those unlikely but not uncommon events.
So
they
maybe
tend
can I get a sense from you? Cardiologists are moving more and more into dual therapy, extended dual therapy, switching from clopidogrel, ticlopidine to clopidogrel, now to ticagrelor and prasugrel. Are you seeing more bleeds and of course NOACs in the ED from these agents, or you don't get a sense that there's increased risk? Because a lot of data shows us that there may be slight increase but not drastic.
Is that question for me?
Yes.
Yeah. Actually, it's very interesting. We don't see that many, not as many as I would think. I mean, I guess there is the issue that we really don't have a means to reverse things, and I mean that's all. And even in the medications where we do have quote unquote a reversal agent, something that works in 60 minutes. A lot of bleeding can occur in 60 minutes, and often, but back to your question, yeah, I must say I'm not seeing that many horrible events, clearly the ones that are, really catastrophic, you remember, but it's not an everyday occurrence that we're seeing that.
Yeah, that's good to know, because I think the downside for extended DAPT or any long periods or antiplatelet therapy is the fear of massive bleed, especially intracranial, especially for cardiologists, I think. Can I get again Sidney to summarize this bit on high bleeding risk and Twilight? Yeah. What is the observation here?
So I think it's gone full circle, because I think when I was training to put stents in, we only did 2 weeks of ticlopidine and aspirin, and sometimes warfarin. Then we stopped the warfarin, and then we went on to doing clopidogrel, 4 weeks of aspirin clopidogrel, and then for any sort of stenting, ACS, etc. Then a full 12 months of that, and then some shortening with cipher stents and drug-eluting stents to about 3 to 6 months. And then, of course, all ACS is 12 months. And now we're going back to monotherapy and then shortening the duration because of the bleeding. It's always incredibly difficult to assess in any individual patient the thrombosis and bleeding risk. And there's so many differences and so much confounding, as you mentioned before, in terms of age, comorbidities, and previous bleeding events, and sometimes unexpected bleeding. So you're right. I think that I'm very encouraged by the Stop DAPT trials, as well as ticagrelor monotherapy in Twilight and in global leaders. So that it means that looks like it could fly if you needed to go a short period where it's like triple therapy, a short period where you're going to give DAPT, and then we can stop and you have a good balance, then reduce the bleeding, because bleeding is driving a lot of events, almost even more than thrombotic events, particularly in Asia, because we all feel that Asian patients have a higher bleeding risk than the thrombotic risk, is slightly skewed. And that is probably a good balance in the long term, a shortening that period and then a longer monotherapy period with a P2Y12 or equivalent. Sounds like it's where we're going to go with more data.
Thanks, Sidney. So maybe just a last address for Dr. Lee. I think Taiwan always come out with very good, societal guidelines from cardiology. Does Taiwan actually have a high bleeding versus low bleeding risk guideline, for example, for the society?
The answer is no. In the guideline, we don't have specific criteria to define which group is high bleeding risk or which group is low bleeding risk. But we in the manuscript, in the text, we do describe that the old patient with CKD, with very low body weight, they are maybe high risk. But we don't have a very specific criteria for high or low bleeding risk.
why do you think that's the case? I know Taiwan always have a good registry and databases in their national healthcare system. So again, I can't grapple because I saw your guideline. You truncate it to bleeding risk, but you don't explicitly state the patients or you don't endorse a score. And I think practitioners on the ground are still grappling with that day in, day out, whether it's mono, DAPT, extended, shortened. I think the crux is bleeding risk assessment versus ischemic risk assessment. So
right. So in our guideline, we only mention about the some bleeding score from the Western countries. In our registry study, we tried to develop some bleeding score in Taiwan, but we, however, found it's very, very difficult to create a real bleeding score for our patients. And in Taiwan, and also many different cardiologists, they have different feeling about the bleeding risk. They have very different opinions about the bleeding risk. They most of the doctors only agree the very common opinion about, as I mentioned, the CKD patient, the old patient, probably they are high bleeding risk. But for other group of patients, they are different opinions. So in the past several years, we abandoned to develop the bleeding risk score. That's the condition we have right now in Taiwan.
No, it's a common condition. It's across the world, Asia, and we found the same in our consensus gathering that we don't have a good score, and even if we endorse a score, no one in Asia will do a scoring chart.
Right.
It's also not validated in Asia, and we chose this binary approach as sort of like some form of advice to think about it. The ABO consensus presented by Jules for the APSC Consensus is not rocket science. It's more binary and more like a guide. Again, not evidence-based. Yeah.
I think your ABO approach is a very good way. It's a broadly cover all those patients we think it's a high bleeding risk, but not very, very specific. I think its ABO approach personally, I think it's a very good way to define the bleeding risk.
Thank you for that. Any other comments on bleeding risk?
Jack, regarding the ABO system, do you have any scoring for the ABO? No.
So we discussed it because actually some advisors like Greg Stone are very heavily opposed to the thinking of binary approaches. Major, minor, there is binary, yes or no.
Yes.
He feels that it should be graded and scored because it's very scientific, right? But on the ground, unfortunately, firstly, again, the same thing occurs. No one's going to score. Even if score, you still have to make a binary decision. So we decided to go with a binary approach because we felt that on the ground, that's how most people function. And unfortunately for binary approach, it's true that you tend to err on the side of caution. You see at 85 years old, but don't have any other risk factor, you think it's high bleeding risk, but may or may not be. So I think for age particularly, we say it's age plus. You must plus for probably liver disease, kidney disease, before you say it's high bleeding risk. So I hope that clarifies. Maybe Eiko, you got a comment?
Yeah, yes. So the Kyoto University, Dr. Kimura, who is the president of JCS 2020 this year, he published a paper showing bleeding risk score from Japanese cohort. And it's published in journal, American Heart Association journal. And so they used some scoring system. And they put several factors, including atrial fibrillation or heart failure or PVD, PAD, etc. And that was incorporated into Japanese guidelines. But it's kind of, too many factors and not practical, not very much practical, in my opinion. That's in my opinion. So I think this ABO approach is more like like our practice. Yeah.
We won't tell Professor Kimura that, please. But but again, I think what Professor Kimura do is observational data. That's probably true, but our ABO approach is to differentiate ischemic and bleeding because a lot of times they overlap. If you tell people that the PAD is also ischemic and also bleeding risk primer is true, but it confuses. So I think what we're trying to do is make it binary and not confusing for people to think about. One last question, maybe I can ask Dr. Xie again, is that for Ticagrelor, I think we hear that in organ failure, like dialysis patient, renal impairment is a risk factor, but in vivo study shows that it's actually more efficacious than Clopidogrel in renal failure patients in terms of efficacy. So if you see a renal failure patient, are you more inclined to give it for efficacy or not give it because of fear of bleeding? That's one. Dr. Xie, you have any opinion?
You mean for the uremic patient?
Yes.
And because as we know, uremic patient also is one of the high bleeding risk patients. So actually, of course, I prefer to give the patient Clopidogrel plus aspirin, and instead of the Ticagrelor plus aspirin. And depends on the patient's situation and to consider the duration of the DAPT treatment. Yes.
So again, a very practical approach.
Yeah.
Although there's some evidence, especially coming out from Professor Han's group in China, that Ticagrelor is more efficacious, particularly in uremic dialysis subgroup patients, actually. While Clopidogrel may not be so effective.
Yes. Yeah.
Okay. Okay.
Jack,
So,
Jack, can I ask the last question for Dr. Echo? Yes, because as we know in Japan, they use a lot of the blood sugar, especially the low dose blood sugar instead of the Ticagrelor or Clopidogrel. So regarding the monotherapy with the P2Y inhibitor after the dual antiplatelet therapy, Dr. Echo, will you suggest to use the low dose blood sugar or not? Or do you have any data regarding this one? Because in Japan, you have a lot of the experience regarding the use of the low dose blood sugar.
That's an extremely important question, but we actually don't have data yet. Okay. And the one thing is Clopidogrel mono use is allowed in or reimbursed in our payment system, but Prasugrel monotherapy is not allowed to be reimbursed. So that's an issue right now. So we actually don't have Prasugrel monotherapy data yet.
Okay, so I see. Thank you very much. Thank you.
So I think we are going to switch on to the last lecture by Sidney. We haven't, since Jules is not here, I was about to ask Sidney about ISA React 5, but maybe we can ask about that after his lecture. Yeah. Sidney.
Okay, let me see. I'm going to
So Sidney, I'm keeping you on the time here. So maybe you can deliver this in 10 minutes.
Let's try. So can you see my screen?
Yeah, go ahead.
Okay. Look, thank you very much. I'm happy to deliver the Asia Pacific Society Cardiology Consensus Statement on the management of chronic coronary syndromes, particularly relating to antithrombotic therapies and my conflicts of interest. And it's kind of picked between vascular beds in terms of coronary artery disease and peripheral artery disease, and chronic coronary syndrome, what used to be called stable coronary artery disease. And we know that the PAD can be symptomatic or asymptomatic, but mostly symptomatic patients have increased event rates. And so the whole idea was really having some sort of practical guide in Asia Pacific to guide this complex field about the management. Obviously not everything, because we cannot be covered in terms of all risk factor management, but obviously certain topics are very relevant and contemporary issues relating to clinical practice for CCS patients. And of course, the identification we mentioned already in the discussion regarding excessive bleeding risk versus high thrombotic risk. And we know that the feeling traditionally in Asia Pacific is that many patients are more prone to bleeding than it is to thrombosis. I'd like to thank you, all the panel that we have recruited, including Jim Montalescot and John Eichelbloom and Keith Fox. And both Jack and I co-chaired this on a couple of occasions. And of course, some of you have already participated. We know that people post-ACS have a residual risk. And this is extensively seen in the first 12 months, at least 15% for combined events, but also it kind of drags on and probably continues to increase with time. And of course, the atherosclerosis is a chronic progressive systemic disease and can affect many vascular beds, and because many arteries are there. Last year, the ESC had an entire statement based on the chronic coronary syndrome, changing the name from stable coronary disease because really is a risk factor, or the event rates are waiting to happen. And they pitched about 6 different clinical scenarios. But one clear thing from our point of view when we're in the discussion is about when do we transit from an acute unstable syndrome, ACS, to chronic coronary syndrome. And most of the time, it's 12 months. Whenever you think patients have recovered from that episode, it could be 3 months or even 6 months before they transit into a stage where they're managed in a more chronic, slightly more stable sense and recovered from the acute coronary syndrome. These are the levels of evidence-based for the recommendations, and I think they're pretty obvious, so I won't go too deeply into that. So we did mention imaging. So coronary angiography and cardiac CT or other imaging techniques may be used where available to confirm the diagnosis of chronic coronary syndromes, and that relates to the definition and identification of coronary artery disease. Of course, it can estimate the extent of stress-induced ischemia and also the burden of the coronary artery disease, and that level of evidence is about level 3. So we wanted all the other risk factors to be managed as per local healthcare guidelines and recommendations. And so that was a recommendation to aggressively manage those. And we mentioned that there's an assessment of bleeding risk versus thrombotic risk and the feeling in Asia. And the key thing is under treatment of underutilization of evidence-based therapies for secondary prevention. Now we did take the point that when we're doing revascularization, particularly percutaneous revascularization, which is favored in Asia Pacific, then use of imaging, if available, if funded, is highly encouraged because as you can see in Japan, low rates of stent thrombosis, which is what we really fear in terms of a thrombotic complication of a revascularization procedure from the acute coronary syndrome. And drug-eluting stents, and which is now almost always, even in the ESC guidelines, is recommended for all PCI procedures, where available should be preferred. And of course, an assessment of the bleeding and thrombotic risk of a patient should be done before you can determine which antithrombotics to use. And this is also consistent with the understanding of we're not going to prolong or extend new antiplatelet agents and combinations. We also looked at somewhat the gender. We didn't think gender should bias the treatment or assessment of bleeding and thrombotic risk. And the development of the ABO algorithm, as discussed and seen with the Dr. Montalescot's lecture, can be used as a binary approach to assess excessive bleeding risk. And that was, I think, an advance in terms of how to make it more practical for clinicians. We also felt that there's often thalassemia traits and hemoglobins may be a little bit lower in Asia Pacific region. There's some data suggests that that's the case. So a level picked at about less than 9 grams per deciliter was used as an indication of actual anemia in Asian patients when assessing bleeding risk. And that's incorporated into the ABO assessment algorithm. And this is what it is. So we know that the ARC heart bleeding risk schema that was published last year, actually age more than 75 was only a minor criterion because of course it's confounded by lots of comorbidities which tend to amass in older people. Advanced age more than 85 years, and Gilles Montalescot mentioned about the Atlantic sub-study, which showed that actually that's quite an independent predictor, regardless of any platelets used in the study, that would identify high bleeding risk. Life expectancy less than 1 year, and bleeding for B, spontaneous intracranial hemorrhage, recurrent gastrointestinal bleeding. That's because usually you can fix the first episode and maybe identify the problem. Hemoglobin less than 9, we've mentioned. In terms of organ failure, we mentioned end-stage renal failure requiring dialysis, bone marrow failure, which is severe thrombocytopenia, platelet count less than 50,000, stroke in the last 6 months, and liver cirrhosis. And so we know that age is very common in bleeding scores, but it's quite confounded, and the elderly are often undertreated in registries. And we mentioned the Antarctic sub-study, and by itself, more than 75 years of age, didn't quite make it. So frailty was added in our schema. You saw the CVD algorithm as well to assess thrombotic risk or high risk chronic coronary syndrome. I'd like to point out that the coronary anatomy in the coronary part was very similar to some of what was mentioned in the ESC guidelines about complex coronary stenting. And we've included left main, bifurcation, and multi-vessel PCI more than 3 stents, and prior coronary event and high-risk coronary artery anatomies. The established peripheral artery disease and cerebrovascular disease can be documented by imaging, such as CT scan, CT coronary angiography, and anal functional testing, and revascularization. Disease with diabetes on treatment, an eGFR less than 60 mils per minute per body surface area, and albuminuria, micro or macro, and heart failure due to coronary artery disease. We know that, these overlap in different vascular territories. At least a quarter of CAD patients may have disease in other vascular beds, and 62 patients of PAD patients in a REACH registry had other vascular bed territories. And each vascular bed addition will increase the risk of cardiovascular events. As you can see in the right-hand side, you go from 1 vascular bed to 3, you double the hazard ratios, event rates at 1 year in terms of having cardiovascular death, MI, or stroke. But interestingly, looking at polyvascular disease, which is very predictive of increased events long-term, also heart failure, diabetes, and renal impairment in the REACH registry appear to be quite predictive of increased risk. Now, in our guidelines, we've sort of mentioned these things, and diabetes with chronic coronary syndrome, 2 to 4-fold increase in mortality risk in the study. CKD mortality risk also increases if you compare 15 versus 60 mils per minute. And actually, albuminuria or proteinuria, we know already if diabetic patients is an independent predictor of all-cause mortality, at least twice the mortality rate. And in the SOLVE study, a 4-fold increase risk of mortality in people with heart failure from coronary artery disease. Single antiplatelet, aspirin, Clopidogrel, or perhaps even Ticagrelor is recommended for Asian patients with low ischemic risk or excessive bleeding risk. And extended DAPT is recommended if you have without high bleeding risk features, and you've also only gone PCI with complex stent features. Now, dual pathway inhibition, because of the COMPASS study, was incorporated in a recommendation, and a strong consensus reached recommended for Asian CCS patients with high thrombotic risk long-term and without high bleeding risk, and who have residual multivessel coronary artery disease or polyvascular disease or prior stroke or MI. Now, we see that in the COMPASS study. I thought we'll look at some of those factors which are seen in the COMPASS study and the event rate reductions you might get. And you can see that MACE events are reduced, and particularly all-cause mortality is reduced by 23%. And of course, the other aspect of peripheral vascular disease is that in the COMPASS trial, dual platelet inhibition, is that we can reduce the risk of major adverse limb events such as amputation. And so this is quite favored. And I think that that's one of the main reasons why not only reducing cardiovascular events, death, as well as major adverse limb events, this was included in the recommendation, particularly when people with low bleeding risk long-term. So I think that was my slides. I hope that wasn't too long. How's that, Jack? I'll unshare. How's that?
Very good, very lucid. Thank you, Dr. Kaul from India.
Nice to see you. So Jack asked me about ISA React 5. Are you muted?
Well, I think ISA React 5 was a very good study, very topical study. It has its problems, which have been highlighted by, especially by AstraZeneca. And but the strength is that both the drugs have been shown to be quite effective, equally safe. Obviously, you have to avoid patients with high bleeding risk, elderly people, and others which they had excluded. And then Prasugrel has come back, at least in my hands, it has come back, because if we see the original study, diabetics were being benefited a lot more. And India has 30 to 40% patients who come for PCIs are diabetics. So we feel that, it may be one of the good things. And in one of our big trials called Tuxedo 2, in which we're doing multi-vessel disease, diabetes, and is a 1,800 patient trial. We are again comparing Ticagrelor with Clopidogrel as the second randomization. One randomization is between two stents, Xience versus one of our Indian stents which participated in that European study, Talent. And this is the second randomization. This again, I think, is going to clarify a little bit, although 1,800 patients may not be the perfect sample size, but this could supplement ESR test 5. Thank you.
Thanks, Upendra. So I think we've reached the hour, but I want to just spend 5 minutes going around my panel. Maybe you can tell me your wish for what you see or your observation or one point that you would like to deliver to your Asia Pacific cardiologist colleague regards to this topic. Maybe I can start with Professor Li Heng. Do you have any last teaching message for the audience?
You mean what further more topics about the AP guideline from the APSC?
No, just any teaching points of all the things you heard today. Just maybe one point that you think people should bring home after this webinar.
Okay, I think the most important take-home message for me this afternoon is about the P2Y12 inhibitor monotherapy. I think it's a very promising strategy for our patient, especially for the high-risk bleeding patient. Although I think the guideline is still emphasize the 12 months DAPT for ACS, but in my clinical experience, many patients cannot complete a 12 months course of DAPT. So I think right now for me the most important lesson I got this afternoon is that I think the P2Y12 inhibitor monotherapy will be a very promising strategy, and probably I think will change our guideline in the near future.
So Roxana will be very happy to hear that. Professor Shea, you have any one teaching point that you're asking the audience to take home today?
For me, when we consider a strategy regarding the duration of DAPT or which P2Y12 inhibitor should be used, I think we should consider the balance between the ischemia risk and the bleeding risk. I think this is most important. Thank you.
A very practical approach, which is endorsed by APSC. BK, your one learning point for the participants today. You're muted, BK, sorry. Maybe you can unmute yourself. Yep.
As I previously mentioned, so actually we consider both risk factors for bleeding and ischemia, but sometimes very tricky is consider both sides. So for this, the use of the Ticagrelor monotherapy is very practical. So it means the risk factors or something. So now we're gonna make some more strong evidence for the use of the Ticagrelor monotherapy. Yes, I think it would be the very ideal strategy for all Asian population.
So second message about monotherapy. Echo, your learning point for the participants?
Yes, it's about the same. And identify high bleeding risk patients, and the P2Y12 monotherapy would be the way to go, in my opinion.
So Dr. Cynthia, what learning point do you want the cardiologist to bring home from the ED?
Well, I really liked the juxtaposition of those two scores that Dr. Lo was mentioning, the ABO score versus the CVD score. And I really like that very global approach to looking at the patient in that balanced way and using those, little aids. I think that's really cool. So that's something I would use.
Thanks. Sydney and me came out with it over a chat at midnight in Sydney in Fullerton Hotel when I flew into Australia to meet him. Sydney, your learning point for the audience. Then I think we should close.
Yeah, look, I think it's a sort of a journey for the patient. And so when you do acute coronary syndrome treatment, I think if we're putting stents, do it well, like the Japanese approach. get the imaging done, get a good thing. You're very, very confident in how you manage then, because the stent is not going to be as thrombotic perhaps, or bypass surgery. So thereafter, it transits into the dual antiplatelet, short time, single antiplatelet, P2Y12, we think. Eventually, maybe just aspirin when it's really, really, you want to minimize risk even more. So maybe that's the transition. And I think the whole journey we're looking at, and the assessment before, and then travel through, I think that's probably what's happening. So I like it. Goes around.
So I think my learning point is that things keep changing. So we just have to keep learning. And I'm very appreciative of the panel here who was very heavily involved in all these trials like Ubendra, ECHO, BK, and engrossed in bringing new evidence out, particularly for the Asian subset, which so far has been underrepresented in trials. So I think please keep up the good work. And I really appreciate your time for today. Sorry I overran by a few minutes, but I'd like to thank everyone for giving your time today. And keep safe, please. Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you, Jack, for moderating it so well. Thank you.
Yes,
Thank
very
you.
good.
Bye-bye.
As always, as always.
Thank you.
Jack, see you.
Bye-bye.
Bye-bye.
Bye.